my name is Divine Adegbie. I'm a 5th year medic at UCL, and today I'm going to talk you through atrial fibrillation in the next 5 minutes, hopefully. So, atrial fibrillation is one of the most common cardiac arrhythmias you're going to come across. It's a supraventricular tachyarrhythmia, so it's basically a fast heartbeat that's occurring from the atria. So its location is the atria above the ventricles. And it occurs due to asynchronous contraction of the atria, so the atria are beating out of sync. Some symptoms and signs would be palpitations, shortness of breath, chest pain, and on examination you'd find an irregular pulse. A typical case history which exemplifies this would be maybe a 65-year-old man who walks into A&E with a background history of hypertension, diabetes, and hyperlipidemia. This is his first episode of rapid palpitations, shortness of breath, and discomfort in his chest. So on examination, you find that he has an irregular pulse at a rate between 90 to 110 beats per minute. Blood pressure may be 110/70, respiratory rate of 20 breaths per minute or so. His heart sounds would be irregular, but no third or fourth heart sound present, and no other abnormalities on examination. So this typically exemplifies the typical symptoms you'd find in AF. Some important, or however unlikely, differentials you must consider would be sinus arrhythmia or ventricular ectopics. So you'd want to investigate this to confirm. So first line investigation would be an ECG. On ECG you'd see something like this. Most important thing you're looking for is the absence of P waves occurring before the QRS complexes, and this typifies AF. So you want an absence of P waves on ECG. Other investigations you might consider would be to find the underlying cause of this would be an echocardiogram looking for structural heart disease such as heart failure or valvular disease. You'd want to do a chest x-ray, so looking for respiratory causes. Lung cancer can be linked to AF. You'd want to do blood, so you'd want to look at thyroid function tests for hypothyroidism. You'd want to check for infection. You'd want to look at blood glucose levels for past diabetes. You'd also want to maybe look for signs of excessive alcohol intake. Now, it's really important that we treat AF because the atria are contracting asynchronously. The blood is not flowing through the heart as it should, so blood tends to pool and form clots, and these clots can travel to other parts of the body and lead to emboli. So it's really important that we treat AF. So the main aims of treatment are to slow down the rate of the contraction of the atria and to control the rhythm of the contraction of the atria so that they begin to contract synchronously. Rate control is often preferred in the elderly and in chronic conditions, whereas rhythm control is often first line in young, reversible, acute AF. So let's say it's an acute situation, someone turns up to A&E with AF. The first thing you want to think about is, are they stable or not? If they're unstable, so they're showing signs of shock, their systolic blood pressure is under 90, they're tachycardic, they have syncope, chest pain, or shortness of breath. First thing you want to do is DC cardioversion. If they're stable, however, but the onset of AF was within the last 48 hours, you'd also want to consider DC cardioversion, or you'd consider a pharmacological cardioversion with flecainide. And you might want to give heparin if there's any delay in this cardioversion being given. If they're stable and they've had the symptoms of AF for over 48 hours, you'd want to start with rate control, so with a beta blocker such as bisoprolol, or a rate-limiting calcium channel blocker such as diltiazem. Then you want to anticoagulate with a DOAC such as rivaroxaban, or with heparin and warfarin combination. After 3 weeks of anticoagulation, then you'd want to cardiovert either electrically, so DC cardioversion, or pharmacologically with flecainide. Other things you'd want to consider, you'd want to correct any electrolyte imbalances as well. In chronic AF, first line is rate control. So you'd want to rate control with a beta blocker or a rate-limiting calcium channel blocker. Then you'd want to control the rhythm, so you do an elective DC cardioversion in this case, giving amiodarone 4 weeks before and 12 months after. You'd also want to consider giving some antiarrhythmics such as sotalol, amiodarone. You might also want to consider AVN ablation in long-term chronic AF. Most importantly, you also want to anticoagulate. So in all of the things I've mentioned, anticoagulation is really important, obviously, because we're trying to prevent emboli. And the things you want to consider with anticoagulation is two things. You want to consider their CHA2DS2-VASc score, and which is their risk of clotting, and their HAS-BLED score, which is their risk of bleeding. And in evaluating their risks on those two kind of scoring assessments, you can use that to decide how you're going to anticoagulate them. Lastly, you might also encounter a patient with paroxysmal AF. So this is AF that terminates spontaneously and lasts under 7 days, for which you'd want to give them a pill-in-pocket approach. So you'd anticoagulate, as I said before, anticoagulate, and you might want to give them sotalol or flecainide PRN, which is as required, and they can take this whenever they feel the symptoms of AF coming on. This needs to be an infrequent management, so this is not something that happens to them frequently, and this is in the case that they have no symptoms of heart failure, so no signs of left ventricular dysfunction and no signs of any blood pressure issues or things like that. So that's a whistle-stop tour through AF. I'd really encourage you to look at NICE guidelines, to look at BMJ best practice, which also has quite good algorithms for treating AF in different situations. I hope this has been helpful. Okay, thank you.